classify the skull, or the bones of the skull, and that is functionally in relationship to what we refer to as a neurocranial aspect or a viscerocranial aspect. Neurocranial aspect, those bones which somehow are surrounding the brain case, the cranial bone, okay? Or organs that directly have vaginated off of the surface of the brain, for example, the organs of hearing and the organs of vision, the lobe of the eye. Visceral cranium is the cranial portion that surrounds the two primary visceral tube beginnings that are coming into basically not only into the deep face but also into the body cavity, and those are the nasal region, the airway, and the oral region, the digestive tract. So those are the two things that we need to consider when we're talking about the neurocranial portion or the visceral cranial portion. Also, we can classify the skull bones in relationship to how they ossify. Okay, there's two basic ossification processes. One of those ossification processes, say, for example, if we go back up here to our neonatal skull, and we see these fontanelles, and we see that the fontanelles now that are covered with some type of an acrylic to demonstrate them, because obviously postnatally or post-mortem they're not going to be there. These are bones that were laid down via this undifferentiated tissue referred to as mesenchyme, and they were laid down as membranes. Okay, and then the membranes had osteoblasts that took over those membranes, and then the osteoblasts became osteocytes or bone. Okay? The primary thing that causes bones like these to grow is related to the structure inside, basically, the neurocranium, referred to as the human brain. As the brain grows, it stretches the membranes, and as the membranes are stretched, they lay down bone. Dr. Hans, I know you followed me the other day. Did Dr. Hans talk to you at all about some of the basic principles of orthodontics? Have they talked about that at all? You know, in orthodontics, we can move teeth, because as we move teeth and we put pressure on the bone in front of the tooth or back of the tooth, depending upon which direction we go, that bone, because of the pressure, is going to be resorbed. However, teeth are in alveolar processes or sockets interconnected by these ligamentous aspects we call the periodontal ligaments or the periodontal membrane. And as those periodontal membranes are stretched, they put tension on the bone behind them that is receiving this pressure, this tension, and they will cause bone to lay down. Otherwise, it would be almost impossible for us to move teeth in bone without actually losing them before the end of the process of an orthodontic case. So, membrane bones and bones that come from cartilage. Cartilage is a precursor in relationship to the floor of the skull. The brain, as small as it is, as light as it is, in relationship to the organism, is actually quite big. So the brain has to have something to sit on while it's growing so that it doesn't distort the structures below it or the structures associated with it. So what happens in endochondral bone formation, or the formation of what we would call cartilaginous bone, is that there's a mesenchymal membrane that first develops into chondroblasts. The chondroblasts become chondrocytes, and they lay down cartilage. Then the chondrocytes are replaced by a type of cell referred to as a chondroclast, which removes the cartilage. Then that removed cartilage is replaced by osteoblasts and then bone. So it's a little bit longer process, but it's a process that is definitely necessary and time to allow for, in the case of the skull, the growth of the brain. In the case of the body, things like long bones, these epiphyseal plates between the head of a long bone and the body of a long bone, which allow for that bone to grow over a period of many years.
summarize that process, it's chondroblasts, chondrocytes, cartilage.
I'll write it out. I'm gonna write it out for you right now. Yes.
Does the term osteocyte fit anywhere here?
An osteocyte is the cell created by an osteoblast. An osteocyte is bone. Okay, osteocyte is bone. So, as I said, I will write it down for you. Okay, so here we have bone development. And we have two types of bone development. One is intramembranous. What happens here, undifferentiated tissue referred to as mesenchyme. Okay, this creates, I guess the best way to call it would be a preosseous membrane. And then this preosseous membrane will lay down osteoblasts. Which will give rise to osteocytes, which essentially is bone. So relatively quick, covering the outside of the skull, the lateral regions of the skull, some of the posterior regions of the skull with the occipital bone, and some of the anterior regions with the frontal bone. Now, we have this type of bone, the chondral, and we have this undifferentiated tissue referred to as mesenchyme. And mesenchyme lays down, basically goes straight to laying down chondroblasts. Primarily in bones in the floor of the skull. The chondroblasts become chondrocytes, or cartilage. The chondrocytes are replaced by chondroclasts, and they are then, what happens is, coming down here, we have osteoblasts replacing them. And the osteoblasts become osteocytes or bone. So it's a little bit more complex process, but it's a necessary process to provide for this young, embryonic, and fetal brain a floor to sit on. Okay. So here is just kind of an overview in relationship to these two types of bone. Really, the membrane bones, the primary membrane bones in the body are associated with the skull. Okay, these large plates of bone here. There's a good reason they show the frontal bone. We'll talk about that in a second. But also bones like the parietal bone over here and some portions of the temporal bone, the temporal scoma. Long bone development with these epiphyseal plates between the head of the bone, here's the femur, and the articulation aspect of the bone, or end of the bone. There are these epiphyseal plates, which are basically cartilaginous plates, which will eventually grow, as the bone grows, cartilage will be in there and eventually be laid down to a point, and then it will start to be replaced by bone, by the same way. Chondroclast will get it out of the way, and osteoblast will take over. Okay. So, intramembranous bone. What are the intramembranous bones? Frontal bone is a very important one. Developmentally, the frontal bone, even though it makes up part of the floor of the skull and the anterior aspect of the skull, is the only bone that makes up the floor that is totally intramembranous in development. Totally intramembranous in development. Okay? Then the parietal bones, these bones of the lateral wall, the maxilla, the upper jaw, the mandible, the lower jaw, except the condyle. Except the condyle. The condyle is actually similar in development to a long bone. There's the head, there's the neck, and in between, early on, there's like an epiphyseal plate. The mandibular condylar neck apparatus is the last portion of the jaws to ossify. Therefore, if you are an orthodontist, you've got to predict all of this in relationship when the ossification of the jaws is going to reach its peak, so that you don't interfere with its ability to grow, or you don't wind up causing it to move too far in any direction in relationship where the dentition are from the maxilla. So the condylar head, that relationship is the last part of the mandible to grow, and is the last part of the jaws to essentially grow. Yes?
So in utero, the mandible is just growing, and then the condyle just shows up just floating, and then eventually they fuse together?
Well, I'll show you that. It's a little bit more complicated. It's a little bit more complicated because these are membrane bones. Most of the mandible is a membrane bone. So you have to try and give this membrane bone some support. So there's a special cartilage that develops adjacent to really the internal aspect of the mandible, referred to as Meckel's cartilage. And Meckel's cartilage hopefully will completely be resorbed over the course of development, so that at the time we have a neonatal mandible, it's gone, or should be gone. Otherwise, that can cause developmental abnormalities. So we'll look at that as well. So mandible, the nasal bones are intramembranous, the lacrimal bone is intramembranous, the vomer is intramembranous, the zygoma, the cheekbones, are intramembranous. Okay? Palatine bone is intramembranous. The temporal bone, that flat outer portion called the scoma, is intramembranous. The tympanic portion, and with the tympanic portion of the temporal bone, is any part of the temporal bone that surrounds the external acoustic canal, okay, the external acoustic meatus. So anything that is surrounding this external acoustic meatus is, for example, a small portion of the petrous temporal, but basically this region that is in front of, or extension off of the scoma, is a intramembranous development bone, and that surrounds this external auditory meatus. The sphenoid bone, its greater wing, this large greater wing that can be seen both laterally, can be seen in the middle cranial fossa, and can also be seen in the posterior wall of the orbit. This process develops intramembranously, but then also the pterygoid plates, these wings that we'll be talking about with the gnathostomatic system, that are attachment points for muscles, are developing from intramembranous ossification as well. And endochondral ossification, almost all of the occipital bone develops endochondrally, but that consists of the portion of the occipital bone that really helps to make up the floor of the posterior cranial wall, the posterior cranial fossa, which concludes the base of the occipital bone. So it kind of surrounds the foramen magnum. The endochondral portion surrounds the foramen magnum. The base actually comes forward and meets the back of the sphenoid bone body, which on the top of that is the sella turcica, where the pituitary gland lies, and that is also an endochondral bone. And those two areas eventually come together to form an area of growth referred to as the sphenooccipital chondrosis, basically a growth point that seems to be helping and pushing the midface forward during development. Yes.
So there's different paths to make bones different, but once they're finished, is there any functional difference between the
No.
bones they grow? Yeah.
No,
Okay.
no, and no histologic difference. Developmentally, yes, but after, we're talking about skull growth can go easily 7 years in some individuals. So the temporal bone is endochondral, other than the squamosal and the tympanic portion. The ethmoid bone, this bone in the center roof of the nasal chamber, is endochondral. The inferior concha, this paired bone that makes up this turbinate bone inside of the nasal cavity, is endochondral. All three of the ear ossicles are endochondral. They're actually interesting where they come from. Actually, two of them come from Meckel's cartilage. Two of them come from Meckel's cartilage, the malleus and the incus. And the third one comes from the second branchial arch, which is associated with also the styloid process of the temporal bone, which is the stapes associated with the facial or the second branchial arch. And then the mandible, this condylar head, has a endochondral type relationship up until the full formation of the mandible, the full growth of the mandible. So if we look at this here, we see that everything in red up in this superior image, everything in red here is intramembranous ossification. Everything in red. We turn the skull upside down, you can see some of that red here, but also in relationship to the palatine bone and to the maxilla, and also this zygomatic process of the temporal bone coming off the skull. These are all intermembranous ossification. Everything here that's white is endochondral. This is the floor. In this case, we're looking at the outside. This is the base of the skull. On the inside, this would be the floor of the cranial bone. We look down here, everything from this portion that is stippled in this kind of grayish stippling, this is all visceral cranium. This is all visceral cranium. Everything that is in white out here is the neurocranium. Okay, so these bones, for example, a portion of the temporal bone, mandible, maxilla, zygoma, portion of the sphenoid bone that you can't see behind the frontal process here of the maxilla, but these are all bones that are associated with the visceral tubular entities. Okay, so once again, the adult neurocranium here showing the portions that are associated with the area covering the brain, or in this case, neurocranium. Doesn't matter whether it's endochondral or intramembranous, if it is surrounding the brain, either the floor, the walls, the roof, that is neurocranial. Thank you. It happens to me all the time, actually. All right, so those are bones that help to give the brain protection. Okay, that's why in many ways we have this hard structure. All right, now here you're talking about this development of the jaws, and this is a very old, okay, probably before many of your parents. Okay. I'm an old fart. So 1966, this book came out, but it had this very unique image in relationship, once again, to membrane bones here, 1, 2, and 3, frontal bone, parietal bone, portion of the occipital bone back here, and to bones that are endochondral, okay, in relationship to portion of the occipital, the temporal, the sphenoid, the ethmoid bones, and then here, some other intermembranous bones associated with the jaws, like maxilla. Premaxilla is something that in humans goes away, but not in canines. Not in canines and not in felines. There is a premaxilla that's present in their skulls, okay? So an incomplete covering of this anterior area during early development of the branchial arches. So we see this. Now this gray rod in here, that is Meckel's cartilage. Meckel's cartilage is something that has to be there to provide for support of this lower jaw portion, the mandible, because it is a membrane bone, and it has some time where it has to develop actually to become a firm bone with osteocytes in here and not be distorted. So what here is this precursor, this Meckel's cartilage, which holds it in place. Basically, it is a strut. It's basically a cartilaginous strut that holds this mandible in place. Now, what happens to it is most of it goes away. Actually, some of it becomes the opening into the mandible for nerves like the inferior alveolar, okay, helping to form this mandibular opening or inferior alveolar opening, and goes a portion of the way inside of the mandible. But basically, it goes away and the bone stays. Now here, the upper portion though of Meckel's cartilage, there are a few things that develop from it. One, we have these two cartilages, the two smaller cartilages, referred to as the malleus and the incus, the hammer and the anvil. But we also have the condylar head coming from Meckel's cartilage. Okay. So this is here temporarily. That has got to be resorbed prior really to birth. Okay, late fetal life prior to birth. Okay. All right, so this kind of completes our overview of things associated with the skull, both from the standpoint of the bones, but also from the standpoint of the development of these bones. Now let's look and see how they work, how this apparatus works, and go to this concept. Okay. So this is one of the reasons why we combine these two courses, to talk about these things from the standpoint of their basic structural formation and their function, and what they are there for in the process of what we call mastication or chewing. So we have hard tissues. Okay, obviously bone is a hard tissue, cartilage is a hard tissue. We have the maxilla, the upper jaw, the mandible, the lower jaw, the temporal bone. The temporal bone is part of the hard tissue because it contains this depression that we call the glenoid fossa or mandibular fossa, which is covered with cartilage as well as the condylar head, which allows for the movement of the mandible in relationship to this upper component, the skull, and the cranium. All of these forces of chewing have to go somewhere. They have to be either absorbed by the dentition or the bone surrounding the dentition, or they are distributed through the dentition, through these bones, into the cranial vault. Okay? So we talk about things, for example, we get more specific, we talk about temporomandibular joint disease. A lot of patients have headaches in relationship to excessive forces that are actually distributed from the jaws into their cranial periosteum, which is highly innervated by sensory feedback. And they wind up having some headaches or relationship to issues where the jaw musculature is working excessively hard or creating forces that over and above what it normally would do on an average individual. Dentition, obviously, I mean, at this point, at least you should know what every tooth looks like, where all the ridges are, where all the grooves are, and these, you should be able to, almost identify one blindfold. Okay. I had an anatomy instructor that kind of believed in that when I was taking head and neck. He used to take bones, put them in a black bag, and then break them. And the only thing, what you had to do is you had to determine not only what the bone was, but which side. Okay. But fortunately, he didn't put any teeth in there at that point. This was actually a dental head neck course. Okay. he was kind of a devil type of he, in the course I took with the dental students, 40% of the dental students failed, okay, out of a class of 150, okay. So, and he had that reputation. Actually, there were other, Dr. Montanazzi had him as a instructor, another faculty member who had him as an instructor, and all the same stories, all these urban legends about it. He's no longer with us. I don't know if that's fortunate or not, but at least for our colleagues at Ohio State. Okay, so we have these articulate cartilages. Now, there's two types of cartilages that we find in the body. There are hyaline cartilages, which provide smooth, enhanced surfaces in joint spaces to allow for a more succinct movement of bones in relationship to one another, or articulations, okay? And these cartilages are always active. The cells are always growing in there. They're the chondrocytes. They're always growing and being replaced. Then we have a cartilage that's found in a few areas of the body, including the jaw. The other area that's found in are what we refer to as meniscal cartilage that sit on a bone called the tibia and articulate with a bone above it called the femur, okay? So these are meniscal cartilages and they are fibrocartilage. Now, fibrocartilage isn't per se like hyaline cartilage. First of all, once it is formed, it's formed, okay? You don't typically see, under normal circumstances, you don't typically see chondrocytes in fibrocartilage histology, unless there are excessive forces being put on it. The other thing is it's more like a very, very dense connective tissue than like cartilage itself, like hyaline cartilage. So it's a very dense area. It is usually in an area that is significant in terms of stress. For example, what's happening at the knee between the tibia and the femur is our entire body is being supported on that, okay? So whatever we weigh, probably 2/3 to 3/4 of our total body weight is being supported on a daily basis as we move through our environment. So that's a lot of force. Okay? In the jaw, as I told you, and I'll say it again, we can elicit forces in chewing that exceed 600 to 900 pounds per square inch. That's a lot, okay? That's a lot for any type of joint relationship. So the condyle has to generate those forces to a certain extent through itself, and then these cartilages lie between it and the temporal bone. The temporal bone you see in the condyle are actually covered with cartilage as well, to provide not only a nice smooth articulation, but also to help become a stress-bearing joint, help the mandible and maxilla be a stress-bearing joint. All right, so let's look at, here's the skull, here's the mandible, the temporal bone, here's the maxilla. Over here, these are the three primary bones associated with the process of chewing or mastication. Here, if we look underneath the cranial base area, here is this area here. This is actually the glenoid fossa, and surrounding it, we'll see that there is a ligamentous capsule that helps hold the mandible and the temporal bone together on each side. Okay, so that's the glenoid fossa. Another name these days that you'll see is mandibular fossa. We take a close-up of this region. We can see certain areas associated with the relationship of the mandible and the maxilla. Here is temporal bone once again. And here is its zygomatic process. Now on the zygomatic process, where it's about just in front of the glenoid fossa, there is a bump on the outside. And this bump on the outside is referred to as the articular tubercle, the articular bump, okay? The mandible condyle does not articulate on that bump, but that bump is important in relationship to support of the relationship between the mandible and the temporal bone, because it's going to be an attachment point, we'll see, for a very dense ligamentous band called the lateral temporomandibular joint ligament. Yes.
Where would the glenoid fossa be on here? Is it 3? 'Cause it's kind of hard to tell in the other
Yes.
image.
Okay, now on the inside, going from lateral to medial, we have this surface, on the inside of the articular tubercle on this ridge that the mandible is going to be running against. And this is referred to as the articular eminence. This is the area of surface that the mandibular condyle articulates with in relationship to the head of the condyle and the temporal bone, okay, on the articular eminence. The tubercle is just a bump supporting a ligamentous attachment to the mandible. Let's see that. Okay. Then we have here this process that sticks down over here on the medial side of this glenoid fossa, and this is called the entoglenoid process. Now, this, I mean, we don't chew in a fashion where we strictly go side to side. We do have a movement that takes us from one side to the other, but in order to do that, we have to move the mandible actually downward and forward to then get it to the opposite side for this process of chewing, okay? We don't chew, for example, like some large quadrupeds, like horses and cows, where we chew just kind of flat plane over very flat teeth, side to side, back and forth, okay? It's more of a circular motion. It's been studied a lot, especially in dentistry in relationship to the process of chewing. Our two primary bones, which are associated with the dentition that we use for chewing, are the maxilla and the mandible. Okay, and the palatine bone provides some support for structures in the back and passageways, but the maxilla, for the most part, is at least the first 6 teeth on each side. The palatine bone will help support these last 2 molars. Here's the second molar and the third molar in this area, but also these openings for innervation of the palatal tissues themselves. Mandible. Now, the things to look at in a maxilla or a mandible is that the maxilla, the bone on the buccal side, on the cheek side, is typically thinner than the bone on the palatal side. Okay. All right. So this has a lot to do, and especially if we look from front to back, we see that there's a little bit less bone on the anterior dentition as opposed to the posterior dentition. So that has to do with the forces that are being generated on these teeth and these processes that we call alveolar processes or tooth sockets. Okay. And here in the mandible, you can see as we go here, very thin in the lingual aspect until we get back to the molars. And then the molars, it's a little bit thinner on the lingual aspect, but it's much thicker on the buccal aspect in relationship to the bone around the molars, first, second, and third molar here, okay? So there is some compensation for the type of forces that would be generated here. The forces are greater as we get closer to the mandibular condyle, and that kind of makes sense. Central incisors were not designed to grind, okay? They were designed to hold, to shear the foods that we eat. They were not designed to grind foods. When you start grinding foods on your central incisors, eventually what will happen to the patient is they will lose them, okay? They will lose them due to excessive force. All right, so here we saw this image the other day. Here is the mandible. Now, we'll talk about each one of these areas here that are highlighted, but we've got two types of musculature that are actually highlighted on this mandible. We have the muscles of mastication. For example, the masseter insertion is over here. The temporalis insertion is over here on this coronoid process. Over here on the inside, this is the insertion point of the medial pterygoid muscle. And then over here, we have one of the insertion points of this other muscle, this other pterygoid muscle called lateral pterygoid, which actually has two heads. One of them doesn't typically insert on this area, but this is called over here the boot. This is called this depression on the medial side of the condylar neck is the pterygoid foveal. And attaching there is the inferior head of the lateral pterygoid. Muscle. Okay, so these are the four muscles of mastication as they attach to the mandible. What are these other lines? These are the point of origin of facial muscles. These are the point of origin of facial muscles. Now, facial muscles, typically, we call them muscles of facial expression, okay? But what are they really doing? They are controlling the openings that they surround. The oral cavity, the nose in particular, somewhat the eye in relationship to things like the orbicular oculi, but they also can participate in forces associated with movement in the mandible. So, for example, this large attachment point down here, this is the attachment point of the platysmal muscle. Something happened. This muscle over here, or this line over here, is the attachment point of the buccinator to this buccal shelf. You haven't had prostatitis yet, right? Okay. Yes.
What does that say? Is it say inferior head of what?
Lateral pterygoid.
Oh, thank you.
Okay, we'll actually see that. Okay, so this is the buccinator muscle. Then we have two muscles here. We have a muscle at the corner of the mouth. Which is called the depressor anguli oris. And then we have a muscle here that's actually covered up a little bit by this in the cadaver or in the individual, and this is the depressor labii inferioris. So a depressor of the corner of the mouth, the anguli oris, and a depressor of the lower lip, the depressor labii inferioris. And then one other muscle that we can sometimes see here is a muscle that's referred to as the Powder's muscle. This is the mentalis. But unlike with the attachments of the masticatory muscles, which are inserting here, these facial muscles are originating from here. Yes?
I'm trying to specify what's
the muscle by number 7.
Platysma.
Thank you.
Okay. And here we kind of see on the inside, over here, this ridge inside, this is actually the Gnathostomatic. Okay, now if we look at the base of the skull here, we see this opening back here, that's the foramen magnum, the occipital bone. And here are the mandibular condyles with these lines going through them here, from lateral to medial, through the condylar head over here, and the condylar head over here. And they've got this big red dot, which is called the basion point. That's also something we'll talk about in orthodontics, okay? The cephalometric point. Now, I'm gonna tell you something. They will yell and scream at you in relationship to not setting teeth in their best articulated position, okay? You will try and do that with things that are anywhere from just direct vision to these very expensive Artinge-axis articulators that you buy, okay? I can tell you this, that there is no individual, well, maybe there's some in the world, that have exactly a normal relationship with these bones. So, for example, what they say from a standpoint of normal is that if you draw a line from the lateral condylar pole to the medial condylar pole, it actually should come to this basion point. This one's close over here, over on the right side, but not on the left side. Okay. So you, because of that, because of the position, you're going to have individuals maybe that are not typically bilateral chewers. They're unilateral chewers, okay? And you'll see more wear on one side of their dentition than you will on both sides of their dentition. Or you'll see individuals that, for whatever reason, when they fracture teeth, they are fracturing teeth more on one side than the other because of the side that they spend the most time chewing.
What are those lines called, the red ones that you drew?
They're just a line going through the condyles.
Okay.
Has no particular name.
And ideally, they're supposed to come together.
Ideally, they should come to this point.
Okay.
The basion point is this point in the center of the foramen magnum, just in front. Okay. This is the base of the skull. So you can see this one comes behind it, this one doesn't even come close, it probably comes back to the occipital condyles. I mean, to the occipital.
How do you draw that one? Like, where is the start of
This is the lateral pole of the condylar head. This is the medial pole of the condylar head. So we'll see this drawing used again. This is an axis that we're drawing through the condylar poles, and we're extending it as far back as we can. And where it should end, as they say normally, it should end here. It should cross the basion. That's probably fewer times than not. Okay? It will come there. And that will have an effect on how patients chew. Okay? Yes?
Is that, like, something with that much deviation correctable with orthodontics?
Orthognathics, where you section the jaws. But if the patient's not having any problems, why would you do that? Okay. You've heard of the term, if it's not broke, don't fix it. Okay. That applies to dentistry as well, by the way. And when you do that, you'll find that you will have more headaches than you can imagine. When you take something that the patient was not concerned about, and sometimes it's an aesthetic relationship, but you'll find that when you do things like that, that sometimes the outcomes are not exactly what you expected. And think about it, it's not just the bone that's moving, it's the muscles that are attached to the bone that are moving the bone. And if you change position of the bone, you change the relationship of the muscles. Okay.
Wait, one more question on the Bayesian plane.
Yes.
Aren't most cephs taken from the sagittal plane? So then like, if you're using it on a ceph, how can you tell?
You can see it.
You can see it?
You can
right
see it,
ceph?
yeah. And you can see, a lot of cephs also, there's an anterior skull image that can be taken with a cephalometric too, or a portion of it. Okay. But the Bayesian point is this point that it is a cephalometric landmark to the anterior midline sagittally of the skull. So they can label it on your cephalometric radiograph, even though it's a sagittal image. Your dad's an orthodontist.
Yeah.
All right, so here we got these two jaw components. The upper jaw, the maxilla, the lower jaw, the mandible, okay? And the relationship of dentition in each one of these jaws, and these portions that are referred to here as the alveolar process, alveolar. Okay, so the dentition are in there, okay? Once again, okay, in each and every one of you in this class, if we took you in to the clinic and we examined your dentition succinctly for the position of every tooth, we would not typically see many of you that had a tooth in the exact same position as your colleague. Okay? We are all different, and that's another thing as a clinician you have to remember. Everybody that comes into your practice and is sitting in that chair is a unique individual, okay? They are not all the same. That would be too easy. That would be too easy. And so they come not only with their, in to see you for whatever aspect, whether it's anything from a prophylaxis procedure to a, implant procedure, okay, they're all different. And probably also from the standpoint of their mental status, they are all different, okay? How they approach dentistry, okay? Dentistry is one of the, coming to the dentist is one of the most feared things in people's lives, okay? They always think you're gonna hurt them. When you don't, they're so surprised that they kind of, I wasn't so bad. But they are all different, just like every one of you is different. All right, so all of these things, you might have talked about these when you were doing dental anatomy last semester. All of these things have been studied, in particular in relationship to how they relate to the dentition. Okay, there was this guy, Spee, who created this anterior-posterior relationship between the tips of the lower cuspid and touches the buccal cuspids of all the mandibular posterior teeth and continues to the anterior border of the ramus of the mandible. Okay, so it actually comes up there. Spee aligned, the curve of Spee is aligned so the continuation of this arc will extend through the condyles. So he was trying to see, here the condyle is really, that's the portion of the mandible, that's the joint. That's the joint of this mandibular bone that is moving. And he's trying to see, as the teeth move, what is their relationship to the condylar head, okay? So he created this curve, and it's outlived him, by the way, for almost 100 years. But if we look here, as it touches the tip of the cuspid, our canine and mandibular buccal cusps, it will eventually come up here and pass through the condylar head. So that is the curve of Spee. Okay. Then Spee wasn't the only one that had to get involved in this. There was this guy Wilson that said, well, let's look at how the teeth are angled buccolingually, and that's something you should know. Okay. So, for example, buccal cusps are typically flared laterally on the maxilla, and the lingual cusps are tipped more lingually. The mandible, the buccal cusps are tipped more lingually. Okay, the whole, so the buccal cusps of the maxilla and the lingual, and the buccal cusp of the mandible, mandibular dentition. Those are really the teeth that most of the chewing is done. Okay. The lingual cusps are basically just something that helps to hold that position on the surface of the tooth. Now, patients will wear their dentition over the course of time. Okay, some more than others. Usually that depends upon either habits, like bruxing type habits, or things like the type of foods they eat. In India in particular, there is a high propensity to chew on these nuts called betel nuts. Betel nuts are very, very hard. They're even harder than popcorn kernels. And so if you chew on those, a couple of things happen. One, your teeth get terribly stained. And two, the amount of force generated in chewing betel nuts actually creates an abrasion on the surface of the, in particular, mandibular molars and maxillary molars. So this was Wilson's curve, bilateral curve from side to side. How, as we go from buccal to lingual in relationship to, in particular, the posterior dentition, what does this look like? And because this type of a movement, buccal lingual, is really correlates to a side-to-side movement in association with the process of chewing. Okay. So here we see Wilson's curve. Here we see it kind of highlighted in the molar dentition, second premolar on the back. Here we see it in relationship really to the second premolar for the most part, going side to side. So because the surface of the posterior teeth conform to a curved plane, this is the curve of Wilson. The crowns of the mandibular posterior teeth must incline to the lingual, while the crowns of the maxillary posterior teeth must incline towards the buccal. Okay. So as they move side to side. And then the fossa, as we go back, obviously, the molar teeth versus premolar teeth, it is much deeper as we go posterior. Then there was this guy who took it to kind of an extreme, and this is Monson's curve. Well, it's not too much different than Wilson's curve. The only difference is what Monson said, if you can continue this curve all the way up from an equal diameter, the top of the curve would actually come through the glabella. It would come through the glabella, okay? It would be an 8-inch sphere. The center, I'm sorry, come over the glabella, the region of the glabella. The center is the glabella. Okay. So the upper point of this curve from a diameter type radius would be from the glabella to the side, to the up, down, and so forth. This was Monson's curve. So, is there any, when you use, have you used like Facebos and things like that here? Facebook transfers, you learn that, okay, that process? Next week, prosthodontics, removal process. Okay, so what over the course of time they were trying to do is they were trying to find reference points they could use for, in particular, when these guys were around, not many people went their whole lives with their dentition. So they were replacing the dentition, and they wanted to know where do we put the teeth in relationship to these prostheses that we were constructing for living chewing. So these curves, like curves of speed, Monson's curve, Wilson's curve, they came into play to try and find a position where we can use as a reference point for these chewing curves, basically, for these masticatory surfaces as they came together. If you look at the teeth, we'll stop after this. If you look at the teeth, okay, you look at, here's the mandible, and there's typically if you go through the long axis of each mandibular tooth root, you'll see that not only do they have more of a posterior to anterior tilt, but they also have a lateral to medial tilt, where the forces of this are actually being generated through the roof of the mouth, through the maxilla. Okay, that's where from a physics type of perspective, where the force is going through the roof of the maxilla. Okay, this is in a book that's actually quite good. for dental anatomy. I don't know if you use it. The author, I think, is Abrahams. But a lot of interesting things shown from the perspective, not only using these angles, but he also, as secondary images, he then took the jaws away, he just had the teeth kind of suspended. I don't know if he had super glue. It's kind of a force cyanoacrylate, but he has the teeth interconnected to one another. That kind of brings up another story I'll talk to you when you come back from your short break. But here's the maxillary dentition. And we see in the maxillary dentition, we see kind of a similar relationship with some tilting out laterally. But from the same standpoint as we get to go further back, we see that the dentition of the maxilla is pretty much generated over the mandible. Okay, so the forces of chewing have to be balanced by these bones. If they're not balanced by these bones, teeth are going to get moved. Okay, possibly teeth are going to get rocked out of the jaw. Okay, have you done any? You haven't done any restorations yet in a patient. Okay. All you have to do is create a restoration that is 1/100 of a millimeter too high, and you will create a headache in the patient, or possibly over the course of time, you will cause that tooth to be lost. So when you're carving those restorations now with a mannequin, well, a mannequin doesn't really care. Okay, I don't think. But from that same standpoint, if the teeth don't come together, that's way more than 1/100 of a millimeter. Okay, that's way more than 1/100 of a millimeter. If you take a hair and put it between your teeth, you can feel it. Okay, that's how sensitive the occlusal relationship is between the maxillary dentition and the mandibular dentition. Okay, if you take a hair and put it between your teeth, you can feel it. So remember that when you're placing restorations in someone's mouth. Okay, that's how delicate or sensitive it is. Okay, why don't you take a break?